My name is John Oberlin. I'm the Associate Director of Research at Activ Surgical, and today I'll be talking about the superior efficacy and utility of ActivSight laser speckle imaging to ICG-based fluorescence imaging in visualizing in vivo tissue perfusion and vasculature. This is joint work with a lot of my colleagues. Activ Surgical, the company that completed the world's first autonomous robotic surgery of soft tissue, is building hardware-agnostic surgical software that allows surgical systems to collaborate with surgeons. Activ Surgical's patent-protected surgical software platform reduces unintended and preventable surgical complications by enhancing a surgeon's intraoperative decision-making. Activ Surgical is privately held. More information can be found at www.activsurgical.com. The past few decades have brought remarkable advancements in minimally invasive surgery, which have reduced operative trauma and recovery times. Nonetheless, even as surgical outcomes approach those of open procedures, at least 400,000 people die in the U.S. each year as a result of avoidable medical complications, and 26% of all medical errors are preventable surgical errors. Unrecognized injuries to parenchyma and critical structures, such as intestinal ischemia, gastric ischemia, vessel injuries, and duct injuries are significant causes of surgical morbidity and mortality. Therefore, effective determination of blood flow in critical structures is a clinical unmet need. ActivSight is a novel endoscopic visualization system based on laser speckle contrast imaging, which meets the critical unmet need of real-time vasculature and parenchymal blood flow visualization. The current state-of-the-art for these needs, ICG dye visualization, has limitations and falls short of real-time performance. Once ICG has entered the system, dye visualization no longer indicates the presence or absence of flow due to clamping or other obstructions, because interrupting flow does not change the presence or absence of dye. ActivSight is superior to ICG because ActivSight provides real-time display of blood flow and vasculature with minimal latency. ActivSight responds immediately to clamping or obstruction of blood supply because ActivSight directly indicates the presence and absence of flow. It is an objective signal without false positives from lingering dye, requires no drug injection or prep time, and is available at a lower cost. The ActivSight system is compatible with standard 10mm laparoscopic towers. It consists of two components: a reusable hardware-agnostic adapter containing infrared imaging optics, and a custom light source, which adds coherent laser light to the existing white light source of the laparoscopic system. Proprietary algorithms indicate parenchymal tissue perfusion and vascular blood flow in a real-time false color overlay on the standard camera view of the existing system. On the left, we see a typical view through a laparoscope. The tissue being observed is porcine small bowel. A portion of this bowel has been devascularized. It is not immediately clear which segment is ischemic. On the right, we see a false color view of the ActivSight overlay. Blood flow is indicated according to the scale on the right of the image. Warmer colors indicate higher blood flow, and if sufficiently little flow is present, no false color is painted on the image. From this view, it is immediately clear that the segment of bowel in the center is inadequately perfused. This view demonstrates the simplicity of ActivSight. Blood flow and perfusion information is immediately available without the administration of dye or the subsequent waiting period. ActivSight was evaluated during bowel anastomoses and serial devascularizations of mesentery in 14 porcine model procedures. The objectivity of the perfusion signal was validated against an FDA-approved laser Doppler system. ActivSight detected real-time perfusion and vascular blood flow with an average of 150 milliseconds of latency, as opposed to the 30 seconds of latency typical of commercial ICG fluorescence systems, excluding dye preparation and injection time. ActivSight flow values are consistent and repeatable, while ICG intensity values are subjective and must be evaluated within a limited time window. Furthermore, ICG can typically be used accurately only once per procedure. After serial devascularization of the bowel, all commercial ICG systems consistently display false positive fluorescent images due to dye retention, whereas ActivSight displays no such false positives. Here we see the real-time nature of the ActivSight system as it images a devascularized loop of bowel on the right-hand side versus a healthy segment of bowel on the left. Pulses of increased blood flow are visible in healthy parenchymal tissue, but not in the devascularized tissue, and flow through subsurface vessels in the mesentery and bowel is clearly indicated. The well-perfused tissue on the left-hand side appears in an overall warmer color than the devascularized tissue on the right. Furthermore, subsurface vessels are not visible in the poorly perfused tissue on the right because they do not harbor any flow. This makes it clear which tissue is healthy and which tissue has inadequate blood flow to survive. ActivSight tissue perfusion signals correlate significantly with perfusion data measured by laser Doppler systems. On the left, we see a graph comparing ActivSight laser speckle to laser Doppler signals in a subject's fingers over time as a blood pressure cuff is first inflated and then deflated at t = 60. On the right, we see a graph showing the correlation of speckle and Doppler signals versus the pressure reading on the cuff. It is clear in both cases that laser Doppler and laser speckle convey monotonically correlated information. That is, as one signal increases, so does the other, and thus the information may be used interchangeably. However, laser Doppler systems give readings from probes at individual points, whereas ActivSight is contactless and provides information over an entire image in real time. Finally, we see the results of a serial devascularization of porcine bowel. After an initial segment of the bowel is devascularized, ICG is injected to indicate perfusion. In this first column, ActivSight and ICG show the same regions to be perfused versus ischemic. Next, devascularization is continued and ICG is injected a second time to indicate perfusion. In the second column, we see that the ICG from the first application remains in the newly devascularized bowel, which causes a false positive of tissue perfusion, whereas ActivSight correctly indicates ischemia in this segment. In conclusion, ActivSight is superior to ICG-based fluorescence imaging when indicating parenchymal tissue perfusion and vascular structures. It is more efficient, providing real-time display of information with minimal latency of adaptation. It is more effective in terms of objectivity, repeatability, and lack of false positives due to dye retention. And it provides superior usability, requiring no drug injection or waiting, with a reduced cost. ActivSight is the next generation of intelligent light. Thank you.